Good afternoon, everybody. We're excited to have everybody joining us for our first of two webinars that we will be discussing the maltreatment risk mapping that UT Health Science Center Tyler has been conducting with the Department of Family and Protective Services. Before we start, I just want to let everybody know that you can ask questions during the webinar by clicking on the Q&A that is at the bottom of your Zoom window. If you send in your question to us at the end, we will address all the questions that we receive. And if we don't get to your question, we will reach out to you and answer your question at another time. So feel free to ask questions during the webinar and we'll get to them as quickly as we can at the end. So my name is Dorothy Mendel, and I'm an assistant professor at the University of Texas Health Science Center at Tyler and at Population Health, which is an initiative by the University of Texas Systems Administration. Like I said, we've been working with the Department of Family and Protective Services for the past few years to help develop community risk modeling that allows communities as well as the Department of Family and Protective Services to better understand where risk for maltreatment is within the communities and also what is the underlying risk of that, the underlying risks that lead to maltreatment risk. So our general purpose within all of this modeling that we have been doing is really to provide PEI with a strategic view of where to grow and how they need to grow moving into the future, which for a lot of us who are on the ground trying to prevent maltreatment, their growth isn't important because it means that our community's prevention infrastructure can also grow. But with that said, we also didn't just want to leave this as a state tool. We also wanted to give this back to the communities as a way that they can look into their own community's risks, dive deeper into it, and hopefully generate ideas either for strategic planning, grant writing, or generally getting their community to the table together to help address these issues. And so today what we want to do is talk about utilizing these maps from the perspective of a community, not from the perspective of the state. So where we're going with this is an understanding that we all have to be smarter with our resources, both at the level of the community and at the level of the state. And that has led to a big movement within public health as well as in other sectors called precision primary prevention. And the idea behind this is that we need to put intense resources where they are most needed, not where they're not needed, and less intense resources just where people need a push. But in order to do that, we need to understand what that looks like across communities. The other thing that we need to be cognizant of is making sure that we have population level strategies, not just individual level strategies that are direct counseling and clinic interventions that are affecting individuals at a time. But how do we move down Frieden's population health pyramid to actually start changing contexts and changing culture within communities to be able to help buttress and protect individuals within those communities. And as many people on this phone call know, community level risk is really rooted in the idea behind what are called the social determinants of health, or the social factors that lead to health. Where social determinants of health come from is this idea that our community imparts risk on individuals. So whether it's transportation or housing or access to food, these are factors that are determined by the community, not determined by individuals, but they are factors at the level of the community that majorly affect the individual. They affect the individual's ability to get good food, and it also affects the choices and the culture that the individual lives in. So the big thing that, as we're talking about maltreatment risk, and we're thinking about what this looks like at the level of the community, there's one caveat that I just want to lay the groundwork for before we go into the risk mapping. And that is that the risks that we're talking about here are the risks that are held by the community. They're not the individual. So a lot of the risks that we're going to talk about, it may be that some individuals who are at high risk for maltreatment may have some of these risks, but not all of these risks are going to be held by those individuals. So there's that one caveat, that we shouldn't confuse what we're looking at the level of the community with what we know is a risk at the level of the individual. But also the understanding that even low-risk individuals are going to be impacted by these risks that we see in the community. So the entire point behind social determinants of risks, and what the World Health Organization has been saying since they've started this work, is that even a low-risk individual who's living in a high-risk neighborhood is going to have a lot more risk than a low-risk individual who's living in a low or moderate-risk neighborhood. So it gets back to our understanding that the community imparts risk on the individual. So that's also not to say that we should ignore individual risk, because we do need to know about individual risks. And we know a lot about what puts a family at risk, especially for maltreatment and other bad health outcomes. From the perspective of maltreatment, we know that parents who have unrealistic expectations of what parenting looks like are going to be at higher risk. People with families that are socially isolated, who have large amounts of stress on their lives, are also going to be families at individual risk. These models, and this importance to understand what's happening at the level of the individual, shouldn't be lost as we move our attention now to start talking about the risks that we see at the level of the community. And when we think about what we're seeing at the level of the community, there's two important factors that we have to ask ourselves. And these are super important and have been addressed extensively in the literature and extensively in the research. But from the perspective of planning and community strategic planning, I think it's important to think about these as well. You're not going to answer these questions, but they're important questions to consider. Is that whether your community is at risk because you have a concentration of high-risk individuals who are living in that zip code, or is your community at risk because there are structural or contextual factors within your community? And what I mean by structural or contextual factors of your community, that's what I'm talking about, is the community culture. Is there low risk? Is there low access to services? Is there low utilization of services within that community? Or is there a high concentration of crime within those communities? That's a different kind of address. You would address that in a different way at the level of a strategic plan than you would address necessarily a concentration of individuals with high risk. With that said, what I'm going to show you today is not going to answer any of these questions because we did not differentiate individuals at risk versus communities at risk. But from a strategic planning perspective, if you're sitting down and looking at these data, that's something that you should be thinking about. The other thing to think about too is, and an important caveat that I make quite a few every time I talk about this, is when we're also talking about community level risk versus individual level risk, it's important to know that this is not an and conversation. It's an and conversation, it's not an or conversation. We shouldn't be addressing community level risks and ignoring individual level risks, but at the same time, we also shouldn't be doing the other. We need to address both of these at the same time in order to move the needle on maltreatment, and actually to move the needle on any of these health risk factors that we're going to be talking about. We need programming at both levels, and from a strategic planning perspective, for those of you who are on the ground in the community, you should be thinking about both of those levels too. How do you change your culture in your community, as well as impact individuals who really need to be impacted? So now I want to move towards talking about the actual maltreatment risk mapping. And the first thing I want to start off by saying is what I'm about to show you is not the rate of maltreatment in your community. The reason why we didn't present these as the rates of maltreatment is every time I have ever presented rates of maltreatment, the conversation always turns towards CPS and what CPS is and is not doing in the community. This is no longer a CPS issue. This is an issue of prevention. We want to keep kids out of CPS. And so we want to talk about, well, what are the risks that are in that community that lead to a higher maltreatment concentration within those communities. So what we're really looking at is just what's the maltreatment risk. And that for us, and what you are seeing here, like I said, is not the rate. It is an aggregate weighted risk in your community, which is a statistical way of saying we have brought a bunch of factors together, we've added them up, and this is the risk that we see in that community. And what we're going to talk about, what I'm going to talk about next, is really what those weighted risks are in that community and what we brought together to lead to that final answer about whether a community was high at risk or not high at risk. So these are the risk factors that were included in all of our models. And the ones that are in italics are actual factors that are aggregates of additional variables that I want to discuss as well. What isn't in italics are individual variables that we have, like the rate of infant mortality, a rate of assaults needing medical attention for people between the ages of 15 and 45. These are actual measurable variables. And then now we're going to talk about the individual factors. And the factors that are bolded here are the most important factors that we saw across all of our models, across all of our age groups. And they're the ones that I really, really want to focus in on so everybody understands what is going into each of these factors. Now, with that said, I also want to bring everybody's attention to the website. So this is the Maltreatment Risk in Communities website. And when you scroll through this website, everything that I'm going to talk about right now about the underlying risks, the underlying variables that make up these risk factors is located on this website as well. So our families in poverty, as well as all of our other factors, are also explained on this website. So there's another resource that you can go to that actually will help bring out your memory a little bit when you're going back and actually digging down deep into these factors. So families in poverty is what everybody thinks when they think about maltreatment risk. It's become almost a truism in the research that we expect communities that have high levels of poverty to be communities that have high risks of maltreatment. And one of the important things and what we found in this Families in Poverty and the way we put this together is really classic ways to measure poverty. It's places with high concentrations of child poverty, places where there is a lot of utilization of SNAP or WIC or other safety net services. There's a lot of adults without health insurance in these communities, low education, and importantly, underemployment. Not unemployment, but underemployment happens in these communities as well. Also, there's a lot of births to teen moms happening in these communities. And so this pretty much conforms to what everybody believes a community that has a high level of poverty looks like. What's important to understand about what we found in our modeling here in Texas is this is an important factor, but it is not the most important factor that is associated with maltreatment risk in our state. And a lot of this, I think, has to do with we have quite a few communities in the state who have high levels of families in poverty, but appear relatively protected. So the diversity that we have in how much additional risk our families, our communities that have high concentrations of poverty have, that diversity is important to think about when you're thinking about maltreatment prevention and where to go with maltreatment prevention. The factor that we find that is absolutely positively has the most weight in our modeling is a factor that we've called health and disability. And this factor is very much drives our model, and in fact, in our rural areas, this factor explains most of our maltreatment risk in our rural areas. In our urban areas, this factor gets balanced out with a few other factors, but in our rural areas in particular, this is such an important factor in determining maltreatment risk and understanding maltreatment risk. So what underlies this factor is quite a few medical and health behaviors that we see that are highly associated with stress in the family. Smoking during pregnancy, for example. Texas has a very low rate of smoking during pregnancy, so when we do see it, there tends to be something else going on when we have a woman who's still smoking during pregnancy. And a lot of what we see in smoking during pregnancy is a lot of these families tend to have other factors that make us see that they are a stressed family and during that pregnancy. The other important health behavior that we see associated with this factor is very low rates of breastfeeding in the hospital. What we see from our data as well is when women don't breastfeed in the hospital, they're not going to go home and all of a sudden start breastfeeding. So these women and these families are really at high risk for not just health behaviors, health risk for the infant from not having the benefits of breastfeeding, but also through attachment. Breastfeeding, especially breastfeeding early on, right when the baby is born, has a lot of predictive value related to attachment between the mom and the baby. The other thing that we see that also relates back to this understanding that this also looks like a stressed family during pregnancy is that we also have high rates of fathers not claiming paternity among children who are born in these zip codes. And the father not being named on the birth certificate, we know through a lot of both the work that has been done in my office as well as work that's been done across the country, the father not being on the birth certificate places that baby at high risk for maltreatment. That is an indicator for maltreatment risk. With that said, there's also a few other things within this factor that allow us to see that this is also a community that is dealing with a lot of socioeconomic stress. But that socioeconomic stress doesn't necessarily translate into poverty. What that social and economic stress translates into is a high number of vacant housing units within this community. So there's not a lot of people who are living in this community or moving into this community. But the other thing that we see is that these communities also have very low male labor force participation. So there's not a lot of men in the labor force, but also there's a lot of adults receiving disability services. And that is they are specifically receiving Social Security benefits for a qualifying disability between the ages of 35 and 64. So we think that this is also the reason why there's low labor force participation, that people are just being removed out of the labor force because they're qualifying for disability services, so they would not be in the labor force. This particular variable, adults receiving disability, has been one in particular that we've spent a lot of time thinking about what this means and how this relates to the risk that we see within these communities. And it's important to understand who receives disability services and who is qualifying within the state of Texas. First of all, Texas is a very low state for receiving disability services. Only 3.5% of the population, of the adult population in Texas, qualify for disability service, qualify for disability through SSI. But within that group, about a third of adults who receive disability services in the state of Texas are receiving them for a qualified mental health service, mental health disorder. So the 2/3 that are receiving disability because of an injury, most of those injuries, like 70% of those injuries, are chronic lower back conditions. And when you look into the occupational health literature, you also see that those beneficiaries also tend to have a lot of mental health needs as well, because being in pain is not nice. It makes you, people who are in chronic pain tend to also have high rates of anxiety and depression. So when we're thinking about adults receiving disability service and what that means for these communities and what risks that we see in these communities, what we think is that this may be reflective of a concentration of unmet mental health needs in our communities. And what it could also mean is that we have a lot of people who are receiving Social Security benefits, but not receiving other safety net services. So as you guys are looking into how to utilize these data within your communities, delving deeper into who's receiving SSI in your communities and what they need may reflect a little bit more about what is needed in your community generally. The other important factor that we see on our modeling relates back to child health and safety. And I don't think that this is really that much of a surprise to anybody. It makes a lot of sense. But we see that communities that have very high injury rates are communities where we see a lot of maltreatment risk as well. And what's important about that is that these aren't injuries due to abuse. These are injuries that were not due to abuse. So that generally focuses on just safety and parent monitoring within the community. The other thing that we see within this child health and safety factor that is so important is that these communities also have a very high rate of infants going to the emergency department. So parents are taking infants to the emergency department, either for an injury or for a regular sickness. We didn't make a distinction when it came to this. Keeping infants out of the emergency department is a major public health issue. And there's been a lot of work looking at some of the drivers for why parents take infants to emergency departments. And much of that work has focused on access to primary health care, but also importantly, health literacy of the parents. And that relates back to whether the parents, when the parents know to take the baby to the doctor either earlier, or if the parents are taking the baby to the emergency department to receive services that they could have taken the baby to the PCP for. So both of these issues, both injury to children as well as emergency department visits, one of the unifying factors that we see that drive both of these rates is health literacy. So getting to parents and helping parents understand safety issues for their kids, as well as safety issues and when to take the baby to the doctor, are going to be important drivers for understanding the culture of the community when it relates to child safety and health. So the other risk factors that we utilize within our modeling focus on infant mortality, but also the other big one that we utilize is assaults needing medical attention. This is a lot different in the way we've measured this. This is our proxy for violent crime in the neighborhood. And the way we measure this is very different than the way a lot of other people measure violent crime when it comes to modeling for maltreatment risk. Because we are assessing not where the crime occurred, but we are assessing through our modeling where the victim of the assault lived. not where the violent crime occurred. A lot of times what we see is violent crime is occurring in non-residential areas. That's not true when it comes to domestic violence, but a lot of other crime isn't occurring in non-residential areas. However, we still want to know how those assailant, either the victims of the crime or the person doing the assaults, if they ended up in the hospital as well, where they are and where they live, because that may impart cultural risk on those communities. And one of the things that we do see is assaults needing medical attention, especially in our urban areas, is very important in all of our modeling for maltreatment risk. So now I want to back up out of explaining the risk factors and start talking about, well, what do these risk factors mean to you? And how do you use the maps to understand your risk profile? So the first thing to understand is, what age group are you interested in targeting your resources? All of our age groups that we utilize all have different baseline risk for maltreatment. Infants have the highest risk for maltreatment out of any of our age groups, and then 1 to 3 is a little bit higher, and risk trails off as you go into the older age groups. So we broke up all of our profiles by the child's age. And so when you go into our risk maps, you'll see at the top of our risk maps the different age groups that you can look into. So if we go and click on infant maltreatment, that will take us immediately down to our infant maltreatment maps. But if your programming is more focused on 1 to 4-year-olds, or 5 to 9-year-olds, or 10 to 14-year-olds, or 15 to 17-year-olds with the older youth, you can go and look into each of those different maps to identify your risk groups. Now, the second thing to look at is to understand what your profile is. And to understand what your profile is, you need to know where your communities are. And so what I'm going to talk about today is just direct comparison from zip code to zip code. And next week in our webinar, we're going to talk about actually combining zip codes into an aggregate profile. But I'm just going to talk about comparing zip code to zip code. And you need to know where your catchment area is. That's incredibly important, because one of the things that we have found through this mapping is that profiles are incredibly different across our community. And today I'm just going to compare a zip code in Dallas and a zip code in Fort Worth, but this is true across if you're comparing Austin to Houston or Houston to El Paso. All of our communities see this profile fluctuate differently. So it's important to know what your community looks like to be able to understand what steps you need to take to address this in your community. So when you click on a particular map or a zip code within our map, you'll see this profile coming up. And this profile it has no data in it. It's only words. It has no numbers. It has data, but it has no numbers. And it will tell you about what the maltreatment risk is in that community. For example, in this community, it's what we call comparatively high. And then down below, it will show you your risk factors, as well as how this community is doing on its protective factor. And so what I want to do is now talk a little bit about how to read those profiles. So I'm going to do that by focusing on 2 zip codes that we see, one in Fort Worth and one in Dallas, just to show how different these profiles can be. These 2 zip codes have very comparable risk. Their risk ratio is very comparable, but we identify as their level of maltreatment risk. It's very, very close to each other. But when you click on it, what you'll see, we're going to dig into this a little bit more. They're both very high. They're not the highest zip codes on our highest risk level, but they're very high. And then what we're going to do is sorry. What we're going to do is compare the two. But before we compare the two, I think it's important that we step back and really understand what these labels mean and what it means to be among the highest zip codes for maltreatment risk relative to everything else, and what it means to be average. So all of our profiles on these particular maps translate into a Z-score that we're going to talk about next week, about how to actually get the Z-score data for each of your communities. But when it is a risk factor and that community is among the lowest, that community is doing awesome. When we look at the maltreatment, what is the aggregate maltreatment risk in the community, the ones that are among the lowest are the ones who really haven't experienced no child had maltreatment, substantiated maltreatment in CPS data that year. The ones who are comparatively low are also doing very, very well. They're much lower than the state average, half standard deviation below the state average. And additionally, the amount of kids who we see coming into the CPS system is very low. Both of these profiles very much translate into almost no CPS involvement in those communities when we're looking at maltreatment risk. Now, our communities that are average do have risk. These are, and this is important to understand, is that an average community is not a no-risk community. It is a community whose risk is just what we see on average in the state. These communities still have places to go because ultimately we want them to be among the lowest and comparatively low. We want them to their kids not to have experienced CPS involvement. So when we talk about average communities, we shouldn't think about them as being, oh, those are communities we can ignore. They do have risk, and we do need to look into what those community risks are. But when we're thinking about population level strategies, these communities may be the communities that just need a little bit of a push as opposed to intense resources within those communities. Now, when we get to above average, now we're talking about communities who need a little bit more intense resources within them. These are quarters to a half a standard deviation above our mean within our state. These are communities that are starting to see substantial risk across their profile. And these communities deserve our attention as well. The communities, though, where our high intense resources should go are the communities with comparatively high and among the highest risk. Our communities that are among the highest risks, they have a lot of CPS involvement within them, and they rank high on almost every single one of our risk profiles. Our comparatively high zip codes are the ones where we start seeing differentiation across the risk profile. And what we see within an entire metropolitan area, for example, the entire Dallas area, what we see in these comparatively high zip codes can help inform how we can move across and help these zip codes that have the highest risk that we see. So that's what the labels mean. And when you start comparing two zip codes to each other side by side, you really start seeing how these profiles differentiate and start changing between our cities. So for example, within Fort Worth and within Dallas, Fort Worth in particular, across all zip codes in Fort Worth, have very high, comparatively high and very high rankings on their health and disability factor. Whereas in Dallas, it's above average, but it's not really high like we see with the need for intense resources. Where we see the flip, though, between the zip code in Fort Worth and in Dallas is our child health and safety factor. Within Fort Worth, across the entire city, to be honest with you, this child health and safety factor, they're doing really, really well on it. As opposed in Dallas, what we see is this child health and safety factor, especially in this zip code, is very high. And particular zip codes in Dallas where this becomes very, very high. The other big difference that we see between Fort Worth and Dallas is when we look at infant mortality. Infant mortality for our infant maltreatment is very predictive of infant maltreatment for a couple of interesting reasons. What's important about understanding here is that we don't see high infant mortality rates because we see high maltreatment-related deaths. We're just seeing generally high infant mortality rates in these communities. But in Fort Worth, infant mortality rate is among the highest that we see in these zip codes. That rate is among the highest that we see across zip codes across the state. However, in Dallas, it's about average to what we see across the state. So this starts breaking up these two zip codes and starts painting a very different picture of what these two zip codes may need from a programming perspective and from a perspective of bringing in resources. While in Dallas, there seems to be, it may be within the zip code, it may be this issue of coming in and doing a population health push surrounding health literacy that can help address some of these child safety and health issues. In Fort Worth, it seems like they're doing a very good job when it comes to this. So a health literacy push within Fort Worth may not be as effective as a health literacy push in Dallas for addressing this factor. However, when we look at health and disability, while both Dallas and Fort Worth could probably use some help addressing the drivers that we see within this health and disability factor, it seems Fort Worth needs a little bit more help along this way than what we see in this particular zip code in Dallas. So when you start looking through your zip codes and you start looking through your profiles, this is what you're going to start seeing coming out, and this is going to start helping drive some of the decisions on the ground that can be made to help strategically plan to address some of these risk factors. So whenever we're talking about how we can move these data into strategic planning, I think the first question to always ask yourself is, do the data suggest there's a community asset? It's always good to start with what your community has, not what your community doesn't have. And this profile is a good example of how you can look at the profile and start figuring out what are the community assets. For example, in Fort Worth, there seems to be a fantastic community asset surrounding health literacy around safety and health among children. This asset could be utilized to help address some of the other drivers that are of maltreatment that are seen within that particular community. The other thing to also think about is we often focus on these communities, like the two communities I have here, that really need a lot of intense resources. But there's an important thing to think about is whether there's a community who just needs a push. There is value in addressing average risk when they are high on certain risk factors. Because you don't know if that risk factor one day is going to push that community from average risk into above average risk. So there is value in doing less intense resources and population level prevention programming in these communities that really just need a push, whose risk is average, and we want to push them below average. And there's also value in protecting what I call the protected but the vulnerable. And these are adjacent zip codes that we see with very different risks. Now, with that said, I'm also going to say that on the ground, the communities are better to identify the protected but vulnerable than we are looking at just maps. For example, in Dallas, one of the things that we see adjacent to the zip code that we're looking at is another zip code right next to it that is actually lower risk. This community is actually below average on risk and seems to have a lot of protective factors associated with it. We also see a community, a zip code directly adjacent to another zip code that actually has above average risk. And I know you can't see that from these colors, but trust me, you can go click around later and see that this is true. The big question that we have is when we're looking at these maps from our perspective is we're looking at maps that are just zip code boundaries. So we think that these two communities are going to have spillover. But those on the ground in Dallas will actually know if these two communities have spillover or not, and whether these two communities actually influence each other or not. Because of the way that our communities are put together and segregation across our cities and historical segregation across our cities, our mapping may be reflecting historical segregation, or it could actually be reflecting what looks like might be a high-risk community, but is vulnerable, that could use a little bit of help. Otherwise, it could be reflecting a really affluent community that probably doesn't need a lot of resources put into it. And only those of you who are on the ground in your communities can actually really look at these zip codes and tell the difference between the two. But at the same time, I would really encourage everybody to look at that and look at whether there is value in protecting the protected but vulnerable among these adjacent zip codes with very different risk factors associated with them. With that said, that kind of goes over in a very fast way the maltreatment risk mapping that we have and we have put out. And I just want to bring you back to the where the website is. This is our population health, maltreatment risk, and communities map that is our public-facing map. And next week, we're going to talk about a little bit more about some of the more in-depth maps that we have also put out that are a little bit harder to see. So in order to find these maps, you can just go to utsystempophealth.org/maltreatment risk. And these will take you, if you click on any of these links, they will take you directly to the maltreatment risk and community maps. As I said, these maps and what is on this website goes over these risk factors and the variables that are included in the risk factors. And like I said, they also give you the ability to go through the different age ranges, in which age range you are most interested in addressing and most interested in developing programming around. I encourage everybody to go on this website and just kind of click through to identify and find what you're looking for. So right now, I'm going to go ahead and open this up to questions. And so we have somebody who's monitoring other questions are coming in. And if anybody has any questions, we'll give you a few minutes to type them in, and I'm happy to address them now. And while we're waiting for that, I also just want to say that both Molly O'Neill, who's been working on the mapping with me, as well as myself, are very open to being able to provide technical assistance to anybody who needs it, utilizing the maps. And this is our contact information, and feel free to use it and contact us and ask us any questions. Next week, we will be doing a deep dive into how to utilize the maps to actually customize the maps on the website to be able to do needs assessment or to be able to do grant writing. So we have, you can print these maps out, you can aggregate across profiles, across communities. And we're going to be doing a deep dive into that next week. Well, it doesn't seem like we're getting any questions. So with that said, then I will give you 15 minutes of your day back. Thank you so much for joining us. We will be posting the recorded webinar both on our website at texassafebabies.org, as well as the Department of Family and Protective Services Prevention and Early Intervention Division will be posting the recorded webinar on their website and their Learning Hub. Thank you. Have a great day.